Episode 23, Walking but Short of Breath. Welcome to Sports Medicine Case Studies, where I review published case studies in sports medicine. Okay, 34-year-old female visits with her primary care physician with complaints of fatigue and lethargy. She's overweight, she has a body mass index of 24, and has a history of depression for which she has been taking a selective serotonin reuptake inhibitor since the birth of her second child 5 years ago. She has no other remarkable clinical history, including no history of asthma, recurrent bronchitis, or tobacco use. She denies cough, chest pains, palpitations, peripheral edema, and nocturnal awakening with respiratory symptoms. Additional questioning reveals that the patient has avoided recreational activity since adolescence because it was often hard for her. She reported feeling out of breath with mild wheezing and had been unable to keep up with her peers. She had gained 20 pounds since the birth of her second child, which she feels has also slowed her down. A review of the patient's history reveals that until recently she has led a largely sedentary home life and has only recently begun to participate in recreational exercise because of her commitment as a single mother of her 2 daughters. She's also started taking brief walks with her children around the track, which results in shortness of breath within 5 to 8 minutes of beginning exercise. She is not accustomed to this new level of physical activity and is experiencing shortness of breath, chest tightness, and wheezing on exhalation when she exercises approximately twice weekly. Her symptoms resolve with rest or when she drinks coffee. On examination, her blood pressure is 120/80 with a normal heart rate. Head, eye, ear, nose, and throat examinations were unremarkable. Her chest examination was cleared auscultation, and heart sounds demonstrated regular rate and rhythm with no extra heart sounds or murmurs. There was no signs of peripheral edema, and the skin exam was normal. Routine laboratory studies revealed an elevated serum triglyceride level and low HDL cholesterol. My differential: asthma or other pulmonary diseases, cardiovascular disease, vocal cord dysfunction, obesity, deconditioning, or dyspnea secondary to anemia. I want to recognize the authors. Mary Lou Hayden published this article in the Journal of American Academy of Nurse Practitioners in 2012. I'm Scott Hall, a primary care sports medicine physician, and I'm studying for my sports medicine certification exam in 2026. I hope you will join me on the journey. This podcast is for educational purposes only. Okay, additional evaluation. Chest x-ray was performed. It was described as normal. A CBC was also within normal limits. An exercise challenge revealed an oxygen saturation of 99% at rest and 98% after a 6-minute walk. Pulmonary function tests were ordered and revealed normal findings, including a normal flow volume loop, normal lung volumes, and an FEV1 at 90% of predicted. While her baseline spirometry reading was normal, a second spirometry after exercise demonstrated a significant decrease in her FEV1 at 15%. The patient's primary care physician made a diagnosis of exercise-induced bronchospasm. Okay, so I picked this case because it's more typical of patients I would typically see in my clinic, and although the individual described here is not an athlete, I thought it brought up some important points relative to the discussion of exercise-induced bronchospasm. Okay, so exercise-induced bronchospasm is characterized by a transient airway narrowing following exercise, occurring in both athletes with and without asthma. Regular inhaled corticosteroids significantly reduce symptoms in exercise-induced bronchospasm, and short-acting beta agonists taken 15 to 20 minutes before exercise can provide effective prophylaxis, though tolerance may develop with regular use. EIB affects up to 90% of patients with asthma and has a higher prevalence in elite athletes than the general population. It particularly affects endurance athletes, winter sports athletes, and swimmers. The prevalence varies significantly by sport, ranging from up to 45% in summer Olympic athletes and up to 60% in Nordic skiing athletes. However, symptoms alone are neither sensitive nor specific for the diagnosis, as 36% of asymptomatic college athletes demonstrated a greater than 10% reduction in FEV1 on testing. The primary mechanism involves airway dehydration from increased ventilation, leading to an increased osmolarity of airway lining fluid and subsequent release of inflammatory mediators from mast cells and eosinophils. This causes smooth muscle contraction. High intensity training, particularly in cold or dry air, training in chlorinated pools, can also cause airway epithelial damage, inflammation, and remodeling similar to asthmatic airways. Objective testing with standardized bronchoprovocation challenge is essential for the diagnosis as symptoms correlate poorly with actual EIB. Positive test is typically defined as a greater than 10% reduction in FEV1 following exercise or surrogate challenge. Positive test is typically defined as a greater than 10% reduction in FEV1 following exercise or surrogate challenge. Examples of challenge testing include eucapnic voluntary hyperpnea, methacholine challenge test. Resting spirometry is often normal in athletes with exercise-induced bronchospasm. Regular inhaled corticosteroid therapy is the cornerstone of management, significantly reducing EIB with strong evidence. For acute prophylaxis, short-acting beta agonists taken 15 to 20 minutes before exercise effectively prevent EIB, though tolerance develops with more than once daily use. An emerging option is low-dose budesonide and formoterol as needed before exercise, which was shown to be non-inferior to regular daily inhaled corticosteroids with as-needed use of short-acting beta agonists in mild asthma patients. Long-acting beta agonists and leukotriene receptor antagonists also provide protection, but regular beta agonist use may lead to tolerance, reducing bronchoprotection duration. I note that the FDA has issued a black box warning for leukotriene receptor antagonists, including montelukast, which has led to their removal from some recent recommendations for treatment of exercise-induced bronchospasm. This warning, issued in March of 2020, described a warning for montelukast due to serious neuropsychiatric events. The warning highlights risks including suicidal thoughts and actions, depression, anxiety, sleep disturbances, and behavioral change. The FDA recommends restricting use of montelukast for allergic rhinitis in patients who do not respond to alternative therapies. Breakthrough exercise-induced bronchospasm often indicates poorly controlled underlying asthma and warrants increasing or stepping up inhaled corticosteroids and verifying inhaler technique and adherence. Training and warm-up reduce EIB incidence and severity, and athletes should minimize exposure to triggers, which may include cold air, pollution, allergens, and high chlorine levels in pools. Additionally, athletes should be aware of the World Anti-Doping Agency regulations. Most asthma medications are permitted, including albuterol, salmeterol, and inhaled anticholinergics, inhaled corticosteroids, and montelukast, but terbutaline and oral glucocorticoids during competition required a therapeutic use exemption. Okay, questions. A 22-year-old collegiate cross-country runner reports experiencing cough, chest tightness, and difficulty getting a deep breath during the final miles of races. Symptoms resolve within 30 minutes of stopping exercise. She has no history of asthma and her resting spirometry is normal. Which of the following is the most appropriate next step to confirm the diagnosis? A, empiric trial of inhaled corticosteroids. B, chest radiograph. C, exercise challenge with pre and post exercise spirometry. D, a methacholine challenge at rest. E, peak flow monitoring at home. Answer is C, exercise challenge with pre and post exercise spirometry. This is the most appropriate diagnostic test for suspected exercise-induced bronchospasm when resting spirometry is normal. A decrease in FEV1 greater than or equal to 10% after exercise confirms the diagnosis. Key thing I want to mention here, I've seen some differences in regards to how some guidelines recommend providing a diagnosis of exercise-induced bronchospasm. A decrease of greater than or equal to 10% in FEV1 after exercise confirms the diagnosis according to most evidence-based guidelines. History alone has been shown to both underdiagnose and overdiagnose exercise-induced bronchospasm, making objective testing essential. There are several acceptable methods used to diagnose EIB in athletes, including a challenge with exercise, inhaled mannitol, and eukapnic voluntary hyperventilation testing, followed by spirometry. The International Olympic Committee has adopted the eukapnic voluntary hyperventilation test as the preferred method due to its relative ease of completion and excellent sensitivity. Question 2. A 28-year-old professional cyclist is diagnosed with exercise-induced bronchospasm after demonstrating a 14% decrease in FEV1 following an exercise challenge. He has no underlying asthma. He asks about the best way to prevent symptoms during competition. Which of the following is the most appropriate initial recommendation? A. Daily inhaled corticosteroid therapy. B. Long-acting beta agonist 30 minutes before exercise. C. Short-acting beta agonist 15 minutes before exercise. D. Oral montelukast 2 hours before exercise. E. Ipratropium bromide immediately before exercise. So the answer is C. A short-acting beta agonists such as albuterol inhaled 15 minutes before exercise are first-line prophylactic treatment for exercise-induced bronchospasm. Short-acting beta agonists are effective in 80 to 95% of patients and provide protection for approximately 2 to 3 hours of exercise. Long-acting beta agonists are not recommended as first-line therapy for isolated exercise-induced bronchospasm due to concerns about tachyphylaxis or tolerance with regular use. Okay, question 3. A 19-year-old competitive swimmer has been using albuterol before every practice and competition for the past 6 months to prevent exercise-induced bronchospasm. She reports that the medication doesn't seem to work as well anymore and she is experiencing breakthrough symptoms. Which of the following best explains the diminished effectiveness of her current regimen? A. Development of underlying persistent asthma. B. Tachyphylaxis from frequent beta agonist use. C. Incorrect inhaler technique. D. Chlorine-induced airway inflammation. E. Progression to fixed airway obstruction. The answer is B. Tachyphylaxis or tolerance develops with frequent or daily use of beta agonists, leading to reduced duration and effectiveness of bronchoprotection. This is a well-documented phenomenon with both short and long-acting beta agonists. While other options are possible contributing factors, the clinical scenario of daily use with diminished effectiveness is most consistent with tachyphylaxis. Okay, question 4. An elite Nordic skier competing internationally is diagnosed with exercise-induced bronchospasm. He requires pharmacologic prophylaxis and asks about medication restrictions under the World Anti-Doping Agency regulations. Which of the following statements regarding WADA rules and asthma medications is correct? A. All inhaled beta agonists are prohibited in competition. B. Inhaled salbuterol. B. Inhaled albuterol is permitted without a therapeutic use exemption. C. Inhaled corticosteroids require a therapeutic use exemption. D. Oral montelukast is prohibited in competition. And E. Beta agonists require a therapeutic use exemption regardless of route. The answer is B. Under current WADA regulations, inhaled albuterol is permitted without a therapeutic use exemption. Inhaled corticosteroids and oral leukotriene receptor antagonists are also permitted. Certain beta agonists such as terbutaline and oral glucocorticoids during competition do require a therapeutic use exemption. Question 5. A 16-year-old high school soccer player presents with exertional dyspnea and wheezing. She undergoes exercise challenge and her FEV1 decreases by 8% from baseline. Her symptoms during the test were mild. Resting spirometry is normal. Which of the following is the most appropriate interpretation of these findings? A. The test confirms exercise-induced bronchospasm. B. The test is negative for exercise-induced bronchospasm. C. The test is indeterminate and should be repeated with eukapnic voluntary hyperventilation. D. The patient should be started on empiric therapy regardless of test results. E, the patient has vocal cord dysfunction rather than EIB. Answer is B. A decrease in FEV1 of less than 10% after exercise challenge does not meet diagnostic criteria for exercise-induced bronchospasm. The standard criteria is a greater than or equal to 10% decrease in FEV1. This patient's 8% decrease is below the diagnostic cutoff, and the test should be interpreted as negative. If clinical suspicion remains high, alternative diagnoses such as vocal cord dysfunction or repeat testing with a more sensitive challenge may be considered. Final question. A sports medicine physician is counseling a 30-year-old recreational runner newly diagnosed with exercise-induced bronchospasm. The patient is concerned about long-term limitations on her physical activity. Which of the following statements should be included in the counseling? A. High-intensity interval training should be permanently avoided. B. Exercise in cold, dry environments is preferred over warm, humid conditions. C. A proper warm-up period before exercise may reduce the severity of exercise-induced bronchospasm. D. Long-acting beta agonists are the preferred maintenance therapy for isolated EIB. And E. Patients with EIB typically cannot participate in competitive athletics. So the answer is C. A proper warm-up period before exercise has been shown to reduce the severity of EIB and is an appropriate non-pharmacologic recommendation. Guidelines emphasize that EIB should not limit participation in physical activity, including competitive athletics. Cold, dry air exacerbates EIB, and long-acting beta agonists are not preferred for isolated EIB due to tolerance concerns. Thank you.